Okay. Assalamu alaikum, everyone. How is everyone doing? Inshallah, okay. Anyways, my name is Mohammed Alfuwais. For those of you who don't know me, I'm a fourth year medical student, and inshallah for today, I'll be going over a full review for OSPE, okay, as you guys requested. For this session, I need you guys to be fully interactive. Like, I need people to answer me in the chat, and inshallah we can like make a discussion out of it, and I can give you guys some tips and tricks for your exam, some things to focus on, and so on and so forth. So the things I'm going to be going over is all of pathology, like from the first lecture to the 12th, I think, or 14th lecture, which however many you guys had. I'm going to be going over only the microbiology that you guys covered in lab, because most of the question that's going to come in OSPE is just going to come from what you guys took in lab. So it's nothing else. And for radiology, it's not going to be everything, because honestly, me as a fourth year, I have not seen half of these things at all in my life or heard of them. So I'm only going to be going over the main major things that you 100% will be tested, okay, on in radiology. The other things, inshallah, it won't ever come, and it's very, very low yield. Okay, so that's the things I'm going to cross out from this lecture. So to start off, I'll be dividing it into cardiovascular first, and then we go into pulmonary and respiratory later on, inshallah. So to start off with, can someone tell me what's in this image on the left? Hyaline, excellent.
Sclerosis.
Excellent, good. So this is hyaline arteriosclerosis. So what is arteriosclerosis? Oh, and first, arteriosclerosis happens in smaller or medium-sized blood vessels. It's basically the arterioles that's going into the tissues, okay, into the capillary beds. There are two types of arteriosclerosis. You guys 100% defined what this one is, which is called hyaline arteriosclerosis. Excellent. Can you give me the two conditions that you can see hyaline arteriosclerosis in?
Benign hypertension.
Good. And what's the second one? Diabetes. Excellent. So the two important diseases that are related to hyaline arteriosclerosis are diabetes and hypertension. If you want to think about why does it look like this, is firstly, you can see that the walls are kind of thick, okay? And it's one big major layer, okay? So you can see this amorphous pink jelly-like material covering the entire blood vessel. If you think about it in diabetes, you have glucose going into the blood vessel wall, which is going to make it thick, okay? That's number one. Number two is benign hypertension. It's not really that high of a blood pressure. However, it is hypertension still. So for the blood vessel to adapt to the changes in blood pressure, it's going to start to thicken its walls. So this is what happens in hyaline arteriosclerosis, as you guys mentioned. Now, can someone tell me what is on the other image?
Hyperplastic arteriosclerosis.
Excellent, good. So this other one is hyperplastic. Now, hyperplastic, unlike hyaline, is a bit more dangerous. Can someone tell me what is the major condition that is associated with hyperplastic?
Malignant hypertension.
Malignant hypertension, excellent. So this picture over here is actually in the kidneys. You can see the glomerulus over here. So this is a very serious bad complication that happens in hypertension in the kidneys, okay? So as you guys mentioned, easily, it's hyperplastic arteriosclerosis. The finding over here, very important key term that you remember, is onion skin appearance, okay? It looks like if you cut an onion in half, you look at it from the top, it literally looks like an onion, okay? So this is hyperplastic arteriosclerosis. So now, next question. Which of the following is seen due to mechanical injury?
Is it A, Monkberg?
No, it is B. Okay, so B is what, guys? What is B?
Fibromuscular.
Exactly, excellent. So B is fibromuscular. This one over here is A, is, as you mentioned first in the beginning, is Monkberg medial sclerosis. Okay, if you want to just remember the terms itself, it's Monkberg medial sclerosis. So it happens in the media, okay, for one. The second thing is it's sclerosis. Another way you can think of sclerosis is calcification, which is what happens in the walls of, the blood vessels in Monkberg medial sclerosis. So this over here, these deposits are calcification, calcium deposits. Monkberg does not present anything clinically. It just happens in middle-aged women, I think, and there's no clinical implications of it. It does not cause blood vessel narrowing. It does not cause anything. Picture-wise, however, it's very high yield that you remember it for your exam. Okay, very important. You might get a question on it either in MCQ or in OSPE. So remember this image very clearly. For fibromuscular intimal hyperplasia, it's just thickening of the whole blood vessel. Now, in this one, it happens due to, for example, iatrogenic causes. Iatrogenic means if you try to give them like catheterization or anything, the blood vessel might be injured based on this, okay? And it causes this appearance over here. So this over here is, as you guys mentioned, fibromuscular intimal hyperplasia, and it is due to mechanical injury. So now, the next phase is on atherosclerosis. Can someone just broadly define what is atherosclerosis? Simple definition. Hardening of the vessel. Excellent, good. So now, to explain the cycle, then we're going to go into images because it's going to make sense if I describe it first. So firstly, you have a normal blood vessel. You know, nothing is wrong with this blood vessel, for example, over here, okay? Let me switch, actually. Okay, this normal blood vessel. This normal blood vessel will undergo changes. Why? Because it has an insult. It has an injury that's constantly pressuring the blood vessel. So for example, the most common one that we're going to discuss over here is hyperlipidemia. Okay, so high cholesterol that happens in blood. So this high cholesterol is going to start to, you know, there's high accumulation of cholesterol, LDL, and so on and so forth that's happening in the blood vessel. It's going to cause an injury. What's the very first step in atherosclerosis? What's the very, very, very first step in atherosclerosis due to the insult? Endothelial injury. Excellent, good. So endothelial injury, very high to remember. It's the first thing that, you know, goes dysfunction. Okay, is endothelial dysfunction. This endothelial dysfunction, if you think about it, if the walls of the blood vessel gets injured, things are going to start going into the blood vessel now. So what's this thing in this case? For example, LDL. LDL will go and will get oxidized and will basically, because of this oxidation of LDL, it's going to be acting as a foreign body. So macrophages are going to see this and be like, okay, I need to phagocytose. I need to get rid of it. Once they phagocytose them or they uptake the LDL through its receptor, it's going to form a specific type of cell called a foam cell. Now, these changes that happens early on can be seen in patients in young ages. So for example, our ages, you can see this type of change happens. This change is called a fatty streak, okay? Is where you have foam cells that appears in the blood vessel walls, okay? This is called a fatty streak. It happens in younger age groups. The next thing is the blood vessel wall will start to respond to this fatty streak. So what happens is you have smooth muscle proliferation. So once you have smooth muscle proliferation, it's going to go over the, you know, all the foam cells and all where all the cholesterol is at in the blood vessel wall. The macrophages inside the blood vessel walls, okay, and under the smooth muscle cap, is going to start to rupture, okay, because of the accumulation of LDL that they cannot release. Once it ruptures, it forms a necrotic core, okay? So the layers of the walls that we're going to see is firstly a fibromuscular cap and then a necrotic center, a necrotic core. We're going to see it over here. Fibromuscular cap and then a necrotic core in the middle. Okay, so this is where we have a atherosclerotic plaque. It's fully formed now. So now, going from this atherosclerotic plaque, we have some complications that can happen due to atherosclerotic plaque. Number one is it's going to keep on thickening, and it's going to cause stenosis of the blood vessel wall. Okay, significant stenosis. The other one is going to be if it gets occluded by a thrombus. The part of this wall, the fibromuscular cap, it's going to rupture. Okay, it's going to pop. This is going to allow platelets to come adhere, you know, the coagulation cascade to begin and cause thrombosis, and it occludes the blood vessel. The other one is because it will cause weakening of the wall surrounding it. It's going to cause it to rupture, and it might form an aneurysm, and we'll get to what an aneurysm is later. So now, can someone tell me what is seen? Ignore these arrows. I do not think these are what the thing is, but these things, the yellowish discoloration. Can someone tell me what they are? Fatty streaks, excellent, good. So yeah, these are very great, excellent. So what are located in these fatty streaks? What are these cells called? Foam cells, excellent, good. So these are what we call foam cells, okay? So excellent, good job. This is fatty streak, and important, the fatty streak cell that we see is foam cell. Very important to remember. Going on, now, what's the next step after you have a formation of a fatty streak? It's gonna form a full-on plaque. So this is what we call atheroma or an atherosclerotic plaque. You have a fibromuscular wall that's surrounding a necrotic center and necrotic core. Now, I want to mention something to you guys. In inflammation, okay, generally in inflammation, one of the last steps in inflammation is calcification, okay? It's one of the last things that happen in inflammation generally. So with the necrotic core, you will also have calcification. Why do I mention this? Look at the picture on picture C. In picture C, these deposits over here, these are calcifications, okay? So you'll see in the center itself, you'll see some calcifications that happen. Now, because the blood vessel wall is now very thickened in these areas over here, it's going to try to adapt by doing angiogenesis, which is basically new vascularization, formation of new blood vessels. So you can see here, newly formed blood vessels forming here, here, and here, okay? Now this arrow, he's just trying to tell you is now the walls itself, if you have muscular walls, for example, it's no longer going to be as functional. So it's going to cause it to weaken and it may rupture, okay? Now, very importantly, if you guys remember these two things, you have something called a vulnerable plaque and something called a stable plaque. Now, a vulnerable plaque, it's very simple to remember them. The difference between them is the thickening of the fibromuscular wall, okay? So if this fibrous cap or the fibromuscular cap is very thick, it's a stable plaque. If I say it's a stable plaque, does it mean it's going to rupture? Yes or no? No. The most likely complication from this is stenosis. Okay, it's going to cause thickening, and it's going to cause the lumen to be very, very, very narrow. Okay, so this is in a stable plaque. The other one is a vulnerable plaque. It's a very thin wall, so it's most likely going to rupture. Now, what happens if it ruptures? Is this A shows a ruptured plaque? Do you see any thrombosis that's happening here? There is no thrombosis. Excellent, good. Now, what happens here is imagine all the contents of under the fibromuscular cap, all of the necrotic core goes into the lumen. It can go dislodge somewhere else distal to the area, okay? So it can cause still symptoms, okay? So the other one is with thrombosis. Remember these two images, okay? Very important to remember these. This one is with thrombosis. You can clearly tell it's thrombosed. It ruptured. The wall is no longer connected to each other. And then because of because of the rupture of the wall, the platelets and the coagulation cascade can see this and will start to form a thrombus. Here, there's no formation of thrombus. Okay. Now we're going to aneurysms. So aneurysm, it's a dilation of the blood vessel wall. Okay, we know that. Now, can someone tell me what are the two structural types of aneurysms? Okay, good. Okay, DeBakey, 1, 2, 3. That's gonna be for dissections. Okay. For aneurysm, excellent. It's fusiform and saccular. So if you have a blood vessel, normal one, let's just draw a normal blood vessel. It's like this. Okay, one big blood vessel. Okay, let's just say this is the aorta. If we're talking about one of them, which is a fusiform is the whole circumference of the entire blood vessel. The entire blood vessel wall, all sides of it, will dilate. Okay. Now the other one is gonna be the saccular or Berry aneurysm. The saccular is just one side of the blood vessel, like this. Okay. Where do we see the saccular aneurysm? Most common location for these things, or Berry aneurysm. Cerebral. Okay, exactly, in the circle of Willis, most common location in the anterior cerebral artery or the anterior communicating artery. Excellent, good. So this one is most commonly going to happen in the aorta, whether this is the thoracic aorta or the abdominal aorta. Now, what you guys need to know clinically is you need to differentiate the reason or the most common cause of either thoracic or an abdominal aortic aneurysm. So can someone tell me what is one important cause of a thoracic aortic aneurysm? Hypertension. Excellent. Very important to remember hypertension is what causes it. What causes an abdominal aortic aneurysm? Atherosclerosis. Excellent. Good. Remember the differences between the two causes. Very important to remember. For the images, you might see something like this, and it might ask you, what is the cause of this? And as you guys mentioned, very important, very clearly, atherosclerosis is the most common cause for this. Okay. Now for dissection, and one of you already mentioned the baking. The most important thing about dissection is you need to remember how to classify dissections, because you might get a picture like this, one of these pictures, and ask you, how do you classify? Now, just to remember or to note out, it's normally not classified separately, like the Bakey and Stanford separate classification. They're most likely going to say together. Okay, and then we'll practice this together, inshallah. Let me just remove this one second. Okay. Anyways, so the first one is the Bakey. The Bakey, you have three types: type 1, type 2, type 3. Easy to remember. Type 1, all. Okay, ascending and descending aorta. Okay, you can see here, ascending aorta, descending aorta, all of it. Okay. Now, type 2 will just be the ascending aorta. Okay. Now, type 3 is descending. So then for Stanford, it's a lot simpler. It's going to have to involve the ascending aorta. It has to involve the ascending aorta. Whether or not it involves the descending or not does not matter. It has to involve the ascending. The most important thing about Stanford A is ascending. And if you want to remember it, A for ascending. Okay. It has to involve the ascending aorta. For type B, it only involves the descending. It will never involve the ascending. Okay. So now, if I say something is the Bakey type 2, Stanford type A, where is the dissection? Without looking at without looking at the thing. Ascending aorta. Okay, it's ascending only. If it's type 2 and Stanford A, it's ascending. What if I say it's the Bakey type 1? All of it. Good. What if I say it's for example, the Bakey type 3, Stanford type B? Descending only. Excellent. Good. Perfect. Is that clear for you all? Good. So now what can you guys see in this image here? Dissection. Okay, good. So how can you tell if this is dissection or not? Excellent. It is dissection. Look at the mediastinum. The mediastinum is supposed to end somewhere over here. Okay, that's number one. If you look at a patient with aortic dissection, it's going to go from here to here. So as one of your colleagues mentioned, it's widening of the mediastinum. That is the most clear-cut sign on radiology for what a dissection is. Now, clinically, how do you tell if someone has a dissection? Someone has a chest pain, tearing chest pain going to the back. Someone has differences in the pulses in the both upper limbs. So in the right arm, it's different than the left arm. These symptoms, okay? Important to look out for these symptoms. Differences in the blood pressures, okay? And tearing quality of pain that goes to stabbing pain going to the back. That's the most important clinical sign of aortic dissection, okay? Now, what's one important cause of aortic dissection? Okay. Hypertension is a very important cause of aortic dissection. Okay. Marfan is a very important one as well because it causes weakening. You know, this connective tissue disorder causes weakening of the what's it called? Of the walls of the aorta. Okay. So now we're gonna move from that. We're gonna go to vasculitis. Can someone answer this? Which of the following affects elderly females causing headaches? Okay. There's differences in chats, and I will explain why. The answer is A. Okay. Can whoever answered A, can you tell me what is B? It's a bit hard to say. Okay, good. So now I'll differentiate them. Okay. A is giant cell arteritis. B is Takayasu. Okay. So now how do you tell the difference between them? Firstly, on the pictures, then clinically, and signs and symptoms and all these things. The first thing is they're both granulomatous inflammations. Okay. So both of them will have giant cells. Okay. And we're not gonna disagree with this. This one over here, Takayasu B, has giant cells. Okay. This thing over here is a giant cell. You can see one giant cell over here. Both of them, A and B, giant cell and Takayasu, have giant cells. How do you differentiate them on histology? Is this. Firstly, giant cell has intimal hyperplasia. If you look at where the media begins, it begins over here and ends over here. This whole thing is the intima. It's huge. Okay. So you'll have number one, intimal hyperplasia. Number two, and this stain right here, this picture is super high yield to remember. Very important to remember what this image, the lower image is. Okay. Is you have disruption of the elastic lamina. If you guys remember, in the walls of the blood vessel, you have the tunica intima, media, adventitia. In the intima, you have the internal elastic lamina, and then you have the external elastic lamina afterwards, or between the media, sorry. So here is one of the elastic lamina, for example, the internal elastic lamina, and it's disrupted. An important sign to see. Very important is you remember this. Dr. Blood loves this sign. Okay. So you have disruption of the elastic lamina. No need to remember if this is internal or external. Okay. That. Then internal, the intimal hyperplasia, and then you have giant cells. Very important three signs. Takayasu will not have any of the other two. Okay. Just giant cells. Okay. Now, how do you differentiate them clinically? Which one happens in elderly females? You guys answered it here. It happens in giant cell. Young females who of Asian descent, it happens more in Takayasu. Now, clinically, they will be very different. Which one will affect the branches of the external carotid artery? A or B? External carotid, A. Okay. Giant cell will affect the external carotid branches. So all the branches going to the head and neck. Okay. This is why it causes headaches. Takayasu affects the arch of the aorta. Okay. So if it affects the arch of the aorta, it will cause also something called a pulseless disease. So you'll have very weak pulses in the upper body. Okay. Because if you need to remember where, the blood vessels are bifurcating from the aorta. For A, it's giant cell, and giant cell will affect the external carotid branches. So, for example, you have the temporal artery. So that's why it will cause headaches, for example. Okay. And what's one important complication from giant cell? Important complication. Blindness. Because, again, it affects the branches of the external carotid artery. Okay. So now, can someone tell me which medium vessel vasculitis is this one? Exactly. Okay, good. So what's the other than pan or polyarteritis nodosa? What's the other one? What's the other medium vessel? Kawasaki. Kawasaki, there's no picture. So if you get anything on medium vessel, it's this one. Okay, just to mention. But how do you tell this is pan or polyarteritis nodosa? Is this two important signs? Firstly, what is this pink layer? By the way, if someone is in, exactly, if someone is in, unmuting, I do not know if you're saying anything. So yeah. This one is not fibrosis, it's fibrinoid necrosis. Okay. So this is fibrinoid necrosis, causes pink material that will align the blood vessel. Very important sign. The other one is, do you see the lumen in this blood vessel? Can you clearly tell where the lumen is? No. What's happening in the lumen? Thrombosis, excellent. Two important signs of polyarteritis nodosa. Number one, fibrinoid necrosis. Number two, thrombosis in the lumen. Okay, very important too. Now, in terms of clinically, this can happen in the GI, can happen in the kidneys, for example, can happen in multiple areas, and it will cause symptoms based on the area. So if you have, and I don't think it's very important for you guys to remember what symptoms it causes, just remember the histology for it. For Kawasaki, you know, you have the strawberry tongue, you have the conjunctiva, you know, the conjunctivitis, and so on and so forth. That's it, okay, for these medium vessel disorders. Now for the hard part in vasculitis is the small vessel ones. Now, can someone tell me what this one is? There's three small vessel disorders, so which one? Microscopic. Excellent. Good. Okay. Now, I will ask you guys three questions. Number one, can you tell me which two areas it affects? Two organs, most important two. Lungs and kidneys. Excellent. Good. Is it P ANCA or C ANCA? P ANCA. Excellent. Is it granulomatous inflammation? Is there a granuloma? No. The most important differentiating points between this and the other two is, firstly, it can affect the kidney and lung, skin, GI, heart. The most important thing to remember is to differentiate this with the other one, which is granulomatosis polyangiitis, okay? To differentiate these two. The first one, that other one, granulomatosis, will affect the kidneys, the lungs, and the upper respiratory tract, such as the nasopharynx. If you see nasopharynx, think that immediately, okay? The other thing, this one is non-granulomatous, no granuloma. It's neutrophils only, okay? Only neutrophils, okay? So you can see here, this is a polymorphonuclear cell. You can see multiple lobes. Neutrophil. There is no granuloma. The other thing is it's P ANCA positive. Is this clear? Remember these three major differences. Okay, next one. Can someone tell me what this one is? If it's, answer this one. Okay. Granulomatosis or polyangiitis. Good. Now, this, to answer your question, if there is nasopharyngeal, okay, or upper respiratory tract infection, or not infection, sorry, manifestations, such as literally this, okay, such as a nasopharyngeal perforation or perforation of the hard palate, or sometimes people will have sinusitis, for example. Think of granulomatosis with polyangiitis, okay? If there is nasopharyngeal or oropharyngeal manifestations, think of that. Three important organs: kidney, nasopharynx, and lungs. Very important to remember these three, and importantly, nasopharyngeal. Next thing, is this C ANCA or P ANCA? C ANCA, excellent, good. This is C ANCA. And this one is the one that's necrotizing. Okay, someone mentioned necrotizing before. This is the one that's necrotizing. So this is a granulomatous vasculitis. So you have, what's the important hallmark in granuloma? What's the important cell or finding you see in granuloma? Giant cells, okay? Once you see giant cell, form of vasculitis, small vessel, think of this, right away, okay? Going to the last one. Which one is this one? Excellent. So this is Churg-Strauss, okay? Or eosinophilic cholangitis or whatever the other name is. But Churg-Strauss is important to remember. What important cell can you see in this? Cell. One cell. That can differentiate all the other ones. Eosinophils. You see these red cells or pink cells, immediately think of Churg-Strauss. Now, generally, eosinophils. When you think about eosinophils, what diseases do you think of? Generally speaking, asthma. Okay, so you think of allergies, you think of asthma. So that's number one. Last differentiating point. Is this P ANCA or C ANCA? P ANCA. So remember these, okay? So remember it's an allergic granulomatosis affecting the GI, the kidney, and skin. It's asthma, associated asthma, very important to remember asthma. Eosinophils, so you might see in the blood tests elevated eosinophils. And it's P ANCA positive, okay? And actually, I saw this in the hospital, a patient with Churg-Strauss, eosinophils were high, P ANCA was positive, okay? And we already know it was Churg-Strauss. So remember these findings specifically, okay? Do you guys have any questions for vasculitis before we move on? Any questions? There? Okay. Now we're gonna go into something I hated in CVP. That's the MI changes. Okay, so can someone tell me how old is this infection? Okay. So this one is specifically, it's not actually 3 to 4 days. This one is specifically less than 24 hours. So within the first day of an MI. So can someone tell me which one? Is it 1 or 2 that's the effective myocardium? 1, and excellent. As someone already mentioned, waviness of the fibers. Once you see wavy fibers, okay, this is a hallmark for the first 24 hours, okay? And you might see signs of coagulative necrosis beginning. So for example, you have pycnosis, so very small, nuclei, okay? And so on and so forth, okay? And all this white spaces that are filling up, between the wavy fibers or the myocardial cells is edema, okay? So you have beginning of coagulative necrosis. So for example, as I mentioned, pycnosis. And then you have wavy fibers at fine. Once you see wavy fibers, think of first 24 hours, okay? You can't see any other, abnormal cells in this one. It's not as prominent as the other stages, okay? This is very important. Wavy fibers, think of it. Now, what is seen in this image? It's not a date. I just want to tell me what you see and why does it happen? Reperfusion injury, excellent. And this is specifically the traction band necrosis, okay? Now, I'll go take you back to POD. Is when you have, for example, a blood vessel that's occluded for a very long time. You have in distal to the occlusion, so after the occlusion, high amounts of, necrosis that's happening because of the less blood supply. So amongst all of that, you have high amounts of calcium, high amounts of toxins that are being released distal. Once you remove the occlusion, all these toxins are going to dump into the normal tissues, including, most importantly, calcium. So calcium will cause contraction. So that's why you see contraction band necrosis, okay? So it starts to contract. And remember this image because he will love the dyes. I forgot. It's like trihexophenyl whatever dye. But anyways, this is the area that's affected, okay? And these are the contraction band necrosis. Remember this histology, the trichome stain, excellent, good. Remember this image, the histology picture. Very important to remember contraction band necrosis, and it's because of the high calcium. So now, can someone tell me how old this infarction is? Okay. This is specifically 1 to 3 days. So between 1 to 3 days. Okay. Go for a more broader answer. So 1 to 3. Okay. What cells, most important cells, do you see in from 1 to 3 days? Very important cells. Neutrophils. Excellent. Good. So the hallmark sign of 1 to 3 days is dense neutrophil infiltration. If you look at these clumps over here, these are all neutrophils. These are all neutrophils. If you look at one of them, for example, you can see 1 lobe, 2 lobe, 3 lobe. Okay, neutrophils, multiple lobes. Okay, this is important to remember these hallmark changes. Now, can someone tell me what happens here? How old is this one? Good, excellent. It is specifically 7 to 10, as you guys mentioned in the chat. Now, what finding do you see? What cells are accumulating here? Macrophages. Now, the first stage, as we remember, is the wavy fibers. Second stage is you have neutrophils that are accumulating. Third stage now, all these neutrophils have uptaken, phagocytosis, all the dying cells and so on and so forth, and they're still dying debris. Neutrophils, what happens is they will die, okay? So you have macrophages that are going to come and uptake them. So you remember these steps. So 7 and 10 days, macrophages are going to come and phagocytose, clean up all the other mess that happened. The dying neutrophils, the dying fibers, necrotic tissue, and all these things, okay? Now, the next step is this. How old is this infarction? Good. 10 to 14. Okay, more than 10. Excellent. Good. What's the blue colored things? If you guys can tell me that. Collagen. Excellent. So this is collagen. Now, what are the red? Granulation tissue. Let's join them together. The red is newly formed blood vessels. You're correct. Okay, it is capillaries and collagen. Combine them together, it's granulation tissue. So granulation tissue is a mixture of two things. You have newly formed blood vessels and collagen deposition. Okay. This happens because you need to restore, blood flow and whatnot. Okay, it's going to try to adapt now. Now, what's the next step is going to be this. When is this? Okay. So for this one, it's, a while later. So 2 months specifically. What's all of the blue? What is this indicating? Scarring, or you can say all of these collagen. Okay. So you have decreased cellularity. If you see these red pockets over here everywhere, these are the actual myocardial cells that are still intact. Okay. The rest is all collagen deposition, all fibrosis. Okay. Is this all clear for the changes in the histology for MIs? There's nothing else to it. You need to remember these images specifically for your OSPE. Okay. Now, can someone tell me what's the most common complication from an MI that leads to death, like instant? Okay, it can happen immediately after MI. Arrhythmia. Excellent. Good. Now, can someone tell me what can happen around 1 to 3 days? What can cause, for example, friction rub, a sign, a physical sign? 1 to 3 days later, so on and so forth. Pericarditis. Okay, and more specifically, excellent, fibrinous pericarditis. Dressler's is later. Okay, very late. Okay, Dressler's is within a month or two later. Okay, that's when Dressler's pericarditis happens. The difference between fibrinous and Dressler's, fibrinous is because of where the pericardial tissue is. So the area that's being infarcted will send out toxins and so on and cause inflammation to the pericardium right next to it. That's what fibrinous pericarditis due to an MI is. Instant, like within 1 to 3 days. Dressler's is because of the antibodies that form, it causes Dressler syndrome. Okay? So that's why it's later on. Anyways, pericarditis. Can you guys give me some other complications? Just throw complications, no matter the date. Give me like 3 more. Rupture. 1. Aneurysm. 2. Congestive heart failure. Good. So now, can someone tell me what this is? Ignore. Okay, good. This is pacemaker. Can someone tell me what's wrong with the heart? Good. Left ventricle dilation, or we could say what's one of the complications as we already mentioned. Okay, I'll mention. This is an aneurysm. Okay, this is a ventricular wall aneurysm. Okay, this is one of the complications that can happen. This specifically, I don't think will be tested, but just to test your concept into knowing what the complications are, because you will be tested on the complications. Specifically, out of all of them to remember, Dressler's, fibrinous pericarditis, the 1 to 3 days, and arrhythmia. Arrhythmia, I would say almost 95% will come, okay, from an MI. So now, next thing. Can someone tell me what type of pericarditis is shown here? Fibrous. Excellent, good. Now, for fibrous pericarditis, can someone tell me some causes of fibrinous pericarditis? MI, uremia. Okay, good. So MI, uremia, viral infection, so on and so forth. So this is something right heart failure can cause it. It's okay. So this is fibrinous or serofibrinous pericarditis, where you have, for example, serous fluid that will then be fibrous. So a very key term that I will mention to you guys, and in the scenario, it will come like this. Bread and butter type of pericarditis. Okay, it will show appearance as if bread and butter. These two terms come, that's fibrinous. Okay, very important to remember these two terms specifically for fibrinous pericarditis, bread and butter. Okay, so this is why it's bread and butter, because once you try to separate the pericardium from the rest of the from the myocardium, it can't. Okay, it can't. It's stuck, and this is mostly going to be between the serous and the what's it called, the visceral layers of the pericardium. So not the myocardium, between the serous and the visceral pericardium. If you try to separate them, you can't. Okay, that's why we call it bread and butter. For histology, it's not really important, but you can just see a fibrin network, which is why it's attached to each other now. Okay. So what type of pericarditis is this one? So this is suppurative or purulent pericarditis. You see high amounts of neutrophils. It's very destructive, inflammatory. This is very acute also. So it's more likely a bacterial infection that's causing it, the purulent suppurative pericarditis. That's why it's suppurative. Okay, there's pus formation. So this is more acute, rapidly progressive. They have signs of like high fever and so on and so forth. You see histology, and it's very, hypernuclear. There's a lot of cells that's happening, hypercellular, sorry. You might see neutrophils and so on and so forth. Okay, very rapid onset. Okay, so this is it for pericarditis in terms of images. We got this one specifically in our exam, in multiple choice. So remember what this is, the image, and the other one. The other one, bread and butter, key term, okay? So now, we're gonna go into the cardiac tumors. So can someone tell me which one is often singular in adults and causes syncope? B. What is B? Myxoma. Good, excellent. So B is a myxoma. Now, which cardiac chambers is most likely affected? Left atrium. This is why it will cause syncope. What happens is this, firstly, the myxoma is a big mass. It's either, it looks like a polyp-ish. It has a stalk sometimes, a sessile or a pedunculated thing. It's highly, like, there's a lot of blood surrounding it as well. I think there's an image in your slides about it. But basically what it does, it falls into the mitral valve annulus. So if you think about it, this huge tumor, once it goes into it, okay, into the mitral annulus, blood is not going to go into the left atrium for just a periodic time period. So no blood is going to go into your brain, for example. So that's why you fall. That's why you have syncope. Okay. So this is, I think, what they call pin drop or something like that. But anyways, so this is a myxoma. What can you see? These, for example, it's just a cluster of cells, and then a mucopolysaccharide, what's it called, background. Okay, these are the important, and you might see spindle cells such as these. Okay. What is A? Rhabdomyoma. Good, excellent. So rhabdomyoma, it happens in what age group? Kids. Okay. So rhabdomyoma will happen in the pediatric age group, so children, infants, whatever. It's most likely multiple and affects it's the opposite, ventricles. Okay, very opposite than myxoma. Ventricles, children, and it's multiple mostly. The important thing to remember is what is associated with rhabdomyoma. What is the syndrome that's associated, or the disease that's associated with? Tuberous sclerosis. Now, I do not think they mentioned to you what tuberous sclerosis is. If you guys remember from neuro, I think, but neurofibromatosis 1, 2, these neurocutaneous disorders, tuberous sclerosis is one of them, okay? Which causes tumors in so many places, okay? One of them is the heart, and it's rhabdomyoma. You have the important genes that are associated, TSC1, TSC2, very important 2 genes. For the myxoma, it's mostly chromosome, I think 12 and 17, if I'm not mistaken. 12 and 17, I think. So yeah, now for histology, you will see very giant myocardial cells, and you have these white pockets. These white pockets are actually glycogen, okay? And a key term to remember are spider cells. I genuinely do not know which one looks like a spider here, but I'm gonna guess it's this, okay? Where it's like, it has like a small body and then a big body after it. This is what I associate with a spider. If you can see, this is the smaller body part, and then this is the bigger one. This is why they say it's a spider cell. It looks like spider cells, okay? So another one is like this one, small body and then a bigger one, okay? So this is spider cells and rhabdomyoma. Next one. The next few slides, I'm just going to be explaining it very fast because I do not think it will be very important for your OSPE. However, it's important to remember. This one, hemangioma, you have multiple types. All of these are hemangiomas, okay? And I do not think you need to differentiate the types of hemangioma based on the images, okay? Not important, I think. If he asks you anything, C is bigger, okay? The image C, this one, the lower one, it's a bigger tumor. think of cavernous hemangioma, okay? Very big dilated blood vessels and so on and so forth. This is blood vessels. This is, sorry, cavernous hemangioma. The rest are all not important. This one could be a pyogenic granuloma, which is also hemangioma. It's a form of it. Most likely what happen in children, you'll see a big red, mass that forms like this, and it more usually it increases in size, then it regresses. Okay, it will shrink, and it's usually goes away on its own. This is what hemangioma is. Benign tumor of blood vessels. The counterpart to it is in lymphatics. Okay, for lymphatics, what's the most important differentiating histologic appearance between this one and hemangiomas? Just one finding. No RBCs. It's lymphatics. Good. This all is lymph. So there's no RBCs. You don't see any red blood cells. So these are lymphangioma. This is a type of lymphangioma. It's called a cystic hygroma. You don't need to remember what that is specifically, but it's a big, big mass. It's a lymphangioma. Okay, it's a huge, huge, huge mass. And that's it you need to know for cystic hygroma and lymphangioma and hemangioma specifically in terms of histological and OSPE. Glomus tumor, also another one. It's another endothelial cell tumor. Okay, so it's usually under the nail bed. Very painful. Okay, they're going to describe it to you very, very, very painful. And it's associated, in the cells that are regulating thermoregulation, I think, okay, is what I remember for glomus tumor. Very painful tumor, this one. So that's it in terms of appearance. If you see something that's involving the finger, it's a very painful tumor, think of glomus tumor. Now, Kaposi sarcoma. The next two tumors, I very highly doubt they'll ask you an OSPE. However, you need to differentiate them based on in MCQs, okay? So that's why I'm going through these ones very fast, because I want to go through the more important concepts after this. So Kaposi sarcoma, there's AIDS-related, HIV-related, Kaposi sarcoma. There's 4 types, I think, in your slides. Remember how to differentiate them? Now, in terms of presentation, it's going to form on the skin mostly. You'll have patches, I think, and then you have papules or plaques like this, and then nodules, I think, is what he calls it, these big ones, okay, nodules. Histological appearance, not too important. Spindle cells, that's the important finding, and you have highly, malignant features. So, for example, the NC ratio and all these, normal malignant features. And these two, by the way, are the malignant ones, okay, or the metastatic ones. Angiosarcoma, that's the other one, the counterpart. From all of this image is the most important thing to remember from angiosarcoma. What CD marker is it positive? CD what? CD31. Excellent. Remember CD31. For appearance, it's not too important. For what causes it, you can think of what's it called? Arsenic, I think, is what causes it. Some other, there's like a line in your what's it called? There's a line in your slides that has like arsenic or something and like 2 other things. Yeah, PVC. Very important to remember PVC. He loves asking about that actually. And like he'll mention it in the scenario. He's been exposed to PVC or corotras or whatever, and it's led to this tumor that forms. It's angiosarcoma. Remember that key term. Okay. So now we're done with all of that. Any questions from all the things I've done so far? I guess it's clear. Okay, moving on. I'm going to read the case, and we go on with the case one by one. Okay, 38-year-old man is brought to ER because of a 3-day history of fever, chills, and generalized weakness. And remember, 3 days. Okay, he has been using intravenous cocaine and heroin for 6 years. His temperature, he is febrile. There are retinal hemorrhages with pale centers. Transthoracic echocardiography, echo, shows multiple vegetations on the tricuspid valve and moderate tricuspid regurgitation. What do you guys think this is? Excellent, mashallah. Infective endocarditis. Okay, good. Let's stop there. Let's not mention any more findings. Okay, let's move on. If you want to diagnose this patient, what sample you need is blood culture, obviously. Okay, it's a very important thing to request blood culture. Which one do you use? A. Why A? Why do you pick A? Why is it A? Exactly. Excellent. You need one aerobic, one anaerobic. One way is you know the caps, but no one's going to memorize the color caps. Not going to lie, I didn't. Read the bottle. Okay, aerobic, anaerobic. Done. Okay. It says it on the bottom. Aerobic, anaerobic. You need these two bottles. And someone already answered how many sets you need? 2 to 3 sets. Okay. That's it. This is the most high yield thing from your micro lab. Okay. Other than that, you need to know the organisms, obviously. Okay. So for that specific patient, what do you think, this patient specifically, what do you think the organism is? Staph aureus. Okay, good. Now, what is this organism? Same. Staph aureus. Good. What is this picture, the first one? What is it showing? What's the name of this agar? Mannitol. Mannitol salt agar. Good. Mannitol salt agar. Is it a selective or a differential medium? Good, it's both. Good. What is it selective for? Staph species. Excellent, because it has the salts that will not allow any other organisms except staph. Staph only. Okay. So this includes other types of staph, not just Staph aureus, all the other ones. What causes it to be differential is what will differentiate, which is the mannitol. Okay. Staph aureus can grow on it. Okay. That's why, or it will turn yellow. Okay. It will ferment it. So that's why it's selective and differential. What is this test one? What is this, the other test? Catalase. Okay. This is catalase. This one is coagulase. Okay. So Staph aureus, is it catalase positive or negative? Positive. Excellent. And then is it coagulase positive or negative? Good. Positive. Gram staining, you'll see gram-positive cocci in clusters. Okay, so this is Staph aureus. That's it. Now, from that patient, which one did it cause? A or B? So this one, excellent, guys. It's B. Good job. So B is caused by Staph aureus. Why? Okay, now I'll explain. So firstly, if you look at the difference between them, B is a lot more worse. Okay, so Staph aureus is one of the major organisms that are very purulent. It will cause severe destruction. Staph aureus in general will cause abscess formations in many places. It causes cellulitis with abscesses. It causes, for example, it can cause what's it called, osteomyelitis, septic arthritis. It causes so many things. One of them is tricuspid infective endocarditis. Okay, now this one is called a ring abscess. Okay, it's a ring abscess formation, and it's much more purulent. It's much more destructive. You'll see it's like, it looks bad. Okay, so this is caused by Staph aureus. Now, things to remember about Staph aureus or acute infective endocarditis, is this. Acute is much more destructive, much more rapid. That's why the patient that we had, it was within 3 days. Okay, and it's associated with IV drug users. Why is the tricuspid valve associated with IV drug users? Why is it specifically the tricuspid? Venous, exactly. So with IV drug users, it's going to go through the venous circulation and all the way back to the right atrium. What's the first valve it's going to say? Tricuspid valve. Is this associated with already damaged heart valves or affected heart valves, or healthy? Can happen to healthy heart valves. Healthy heart valves. Okay. So you'll see a patient who is completely healthy, no past history of anything, and he'll have acute infective endocarditis caused by Staph aureus. The other one, image A, is caused by what organism? Viridans, strep viridans. Okay, excellent, good job, guys. So strep viridans causes subacute infective endocarditis, can happen a few weeks later. It's associated with already damaged heart valves. So you'll see someone with chronic rheumatic fever, for example, someone who had it a long time ago. You'll see someone who had, for example, heart valve procedures already done on them. They'll have a valve replacement done, and they underwent a dental procedure. Okay, very important key terms to remember in this patient. It's not as destructive, does not cause as many, like the high fever and stuff. It's subacute a bit later, and also the destruction itself is not as severe. Okay, so that's it. It just causes these vegetations. That's mostly on which valve? Mitral valve. Good. Okay, excellent, guys. So now for valve vegetations. I will go very quickly. We already mentioned infective endocarditis. Rheumatic heart disease, I'll keep later. I just want to go through these two. LSE, okay, is called Liebman-Sachs endocarditis. Which disease is associated with Liebman-Sachs endocarditis? Important. Systemic lupus, erythematosus, lupus. Okay, SLE. What's important to remember? The one high yield thing to remember about LSE or Liebman-Sachs endocarditis and lupus is it affects one side or both sides of the valve? On both sides. Once you see it affects both sides of the heart valve, it's Liebman-Sachs endocarditis. Okay, very important. Now the next one, there's images on your slides, and I looked at it. I didn't include it here, but I want you guys just to look at one of them, and I'll explain which one specifically. But this one is called non-bacterial thrombotic endocarditis. Okay, so non-bacterial thrombotic endocarditis, there's these big vegetations. It's not associated with any bacterial infections. It's associated to what specifically? One important thing. Cancer, okay? And it's most likely colonic malignancy, okay? Adenocarcinoma of the colon, okay? That's the most important one. That's it to remember here. The important histology feature is it's non-adherent, okay? That's the most important thing to remember from histology. Okay. Non-bacterial thrombotic endocarditis, okay, is highly associated with cancer, specifically the colon cancer. Okay, it's not associated with any bacterial infection, and the histology high, like the very high yield part of it, even though this is low yield itself, is it's non-adherent. You'll see that there's a space between the actual vegetation and the valve. It's non-adherent. That's it that you need to remember for these. Okay. So now, can someone tell me what is seen in this image? Excellent, guys. This is carcinoid. Is this carcinoid tumor or syndrome? This is syndrome. Okay. This is specifically carcinoid heart disease from a carcinoid tumor. This is what was confusing in the lecture, and I'll clarify this concept right now. Carcinoid tumor happens mostly in the GI tract. Okay. It goes to the liver. Okay. It spreads to the liver, and it starts secreting a bunch of serotonin. Okay. This serotonin, since if you think about it, it's going to go through the blood vessels and go all the way to the heart. It's going to go to the right heart and causes tricuspid regurgitation and pulmonary stenosis. This isn't a tumor that can happen on the heart. This is why on the valves itself, it's not actually a mass. It's thickening. It's because of the high serotonin that's going into the heart, it's causing the walls to thicken. Okay? And you can see it's just thickness, increased thickness of the walls. This is not the actual tumor. Okay? The tumor, we'll see it in the lungs later on. I'll show you the ones in the lungs. Okay, this is carcinoid heart disease. And important to remember, it's what metabolite is, will you see in the urine, for example? Serotonin, I want a bit more specific. It's something called 5-HIAA. Okay, excellent, good. That's the important marker. The reason why it only affects the heart, right heart, is serotonin. If it goes to the lungs, it gets metabolized in the lungs. So that serotonin won't affect the left heart. Is that clear? There's two places it gets metabolized, in the lungs and in the liver. That's why I said GI that goes to the liver. It has to go and metastasize to the liver. Then it causes this. Okay, good. Now, can someone tell me what's in image A? Actually, both. It's both caused by the same. Calcification. What's the risk factor for this? Aging or senile calcification. Excellent, good. So these are the aortic valves. Both of them are the aortic valves. Important to remember, the commissures are between the cusps of the valve. It's not affected. Okay, only within the sinuses, he calls it the sinuses of Valsalva, you'll see these calcification nodules. Okay, that's the only thing that you'll see here. This one, it's still the same thing, but this one is it's a bicuspid valve. So you'll see that these symptoms or the calcifications happen at a much earlier age than this, but this one is an elderly. This one is just a bit early. Okay, so that's it for these two. Okay, now can someone tell me what's in this image? In all of the images. Mitral valve prolapse. Good. So this is mitral valve prolapse. And okay, good. So this is ballooning of the mitral valve. You can see here, this is ballooning. You have some thrombotic areas over here, and you have here again the ballooning appearance. For this histologic, what's the most important finding in histology for mitral valve prolapse? Excellent. Myxomatous degeneration. Excellent, good. The myxomatous degeneration, although the valve looks much thicker here, it's weak, very weak, so it prolapse. Okay, so that's it for this mitral valve prolapse. That's the only thing you need to know from me. Now, can someone tell me what this is? Tell me first what the disease is, and then we go to the finding. If you guys want me to give you a case, I can. Okay, let's just say someone had pharyngitis, high fever, pharyngitis. 2 weeks later, came to you with a chest pain, came to you with a joint pain that's moving. There's these rashes that's happening. This is rheumatic heart disease. Okay, so this is rheumatic fever. So rheumatic heart disease, it can affect either the mitral valve, aortic valve. Most important two valves that it affects. Most commonly the mitral valve. Now, it can cause acute changes and then chronic changes later on. Now, it can also cause myocarditis because it can cause pancarditis. Okay, that's the Hart and Jones criterion. Okay, so this finding specifically is what in the first image? The big thing is an Aschoff body. Good. So Aschoff body is a collection of these cells. What are these cells? Anish-Cow cells. Okay, so Aschoff bodies are very important findings you see in rheumatic heart disease. And within it is a cluster of cells, which are Anish-Cow cells, which are macrophages typically, that have a caterpillar nucleus. Okay, you can see the nucleus, this one, and you can see it here also, these cells. Okay, so this is Aschoff body and Anish-Cow cells because of rheumatic heart disease. Now, going back to rheumatic heart disease, if it affects the endocardium, it will affect the valves. So on the valves, it causes something called verruca. Okay, now I'll explain again what rheumatic heart disease very quickly. Rheumatic heart disease is due to molecular mimicry. Okay. If you remember the bacteria, strep pyogenes, okay, group A strep, it has M protein. This M protein is very similar to myosin, which is located in the heart. Okay. So this causes antibodies to go and attack it. So when you see the heart valve itself, it's these verruca. Okay, it's something called verruca, which is all that it is inflammation that's happening in the valve, and you have a lot of fibrin and platelets that's binding. So it causes a line, a very linear line of these, like, for example, these clusters. Okay, so these are what verruca are. Okay, and this is seen in acute rheumatic fever. And I want to mention acute rheumatic fever. Is this clear for you guys? I hope I did not lose you guys. Okay, good. But the next thing is, as I said, that was acute. What happens in chronic? What happens in this first image? What's this first image? Fish mouth appearance. Excellent. What valve is this? If this is a fish mouth appearance, what valve is this? Excellent. This is mitral stenosis. So in chronic rheumatic heart disease, guys, it affects the mitral valve and it causes mitral stenosis in it. And the characteristic finding that you can see in mitral stenosis due to chronic rheumatic fever is fish mouth appearance. Excellent. Good. That's one, number one. How about this one? Which valve is this? The other image. This is the aortic valve. Okay. I want you guys to remember one thing about the aortic valve is this. If we remember calcific changes because of the senile calcifications, it does not cause fusion of the commissures. A chronic rheumatic heart disease, fusion of the commissures. You can see here, this one is still patent. It's still there. Here. It fused. Okay. Once you see fusion of the commissures in the aortic valve, that's chronic rheumatic heart disease. Okay. How do you know if aortic stenosis is due to chronic rheumatic heart disease or calcification? Senile calcification is two things. Number one, fusion of the commissures and coexisting mitral stenosis. Why is coexisting mitral stenosis important? What's the most common valve affected rheumatic heart disease? The mitral valve. Okay, so that's how you tell the two apart. Okay, so that's it for the valve defects. I think that's all that I have for that. Any questions? Yes. Okay, moving on. This one, I do not think this will come in your exam, but to go over it very quickly. The first one is lymphocytic myocarditis. Myocarditis is inflammation of the myocardium. Okay, so A is lymphocytic, and this is due to, for example, viral infection. Okay, so for example, Coxsackie infection. B is going to be hypersensitivity myocarditis because of, for example, due to reaction to drugs or something like that. Okay, so this is hypersensitivity. You can see some eosinophils here. Here it's all lymphocytic. Okay, C is giant cell. Okay, I have no other information based on just it has giant cells. D is due to a parasitic infection. This is specifically Trypanosoma cruzi, or it causes Chagas disease. Okay, so this is the parasites within it. Okay, that's all for myocarditis. I highly doubt this will come. That's just for you guys' information. This is me explaining these images. However, it's just by looking at it. But mostly, if he asks you any of them, it's going to be giant cell or this one, Chagas. This one is a bit too difficult. Okay. So now moving on. What is seen in this image shown? All of them. What is the disease? I want the disease. Dilated cardiomyopathy. Excellent. Good. So this is dilated cardiomyopathy. One of your colleagues already mentioned something called star cells. I will specify what the cells are. This cell over here, this is an enlarged cell. Firstly, dilated cardiomyopathy is one of the two types, or one of the three types of cardiomyopathies. Okay, dilated is when you have hypertrophy in parallel or in series. Which type? Parallel or series? Series. If you think about it, if it's parallel, the wall is getting thicker. Okay, so this is hypertrophic. If it's parallel, if it's series, it's growing next to each other, so it's getting bigger. However, it's getting thinner. Okay, so that's that. So that's why it's dilated. There's more space now. So this causes mostly systolic heart failure. It's no longer going to pump as good as anymore. So you have reduced ejection fraction in these patients. So the histologic finding that I want you guys to remember is these ninja stars, nuclei. Okay, ninja stars. Okay, it looks like a ninja star. Now for the causes of this, remember that it can be mixed, environmental or genetic. Genetic, what mutation? Most important mutation. Okay, dystrophin is correct. Titin is the most important. Okay, that I remember. Titin is very important. Dystrophin is correct also. Good. Now, what is this one? Okay, good, excellent. This is arrhythmogenic right ventricular cardiomyopathy. Now, this one is associated with a condition. I forgot what it was called, but there's hyperkeratosis in the skin, I think, and in the hair. Okay, so you'll have high amounts Naxos syndrome. Thank you. So this is Naxos, part of Naxos syndrome. That's part of it. Now, in terms of the finding, this picture is high yield in your exam. Very important. You remember these three: dilated, arrhythmogenic, hypertrophic, and some of the causes of the restrictive. And I'll show you which ones. Okay. This one, firstly, the right ventricle walls is very, very thin. Very thin. Look at the right ventricle here. Very thin. Okay. It's firstly fibrosed, which is this area right here. And you have fat infiltration. This is the actual normal myocardium over here. And you can see it's normal wall. This part is very thin and fibrosed. And you have here fat cells all over. Okay. So this is arrhythmogenic right ventricular cardiomyopathy. Next one. What disease is this? Excellent, good. This is hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, is it genetic or environmental? Genetic. It's purely genetic. Okay. So in hypertrophic cardiomyopathy, you can see, firstly, thickening of the walls. So the walls are growing now in parallel, not in series anymore. Okay, so it's very, very thick. What causes the symptoms is obviously, firstly, you'll have, if it causes heart failure, it's not going to be in systolic heart failure, it's diastolic. It's not be able to fill all the way anymore. Okay, the compliance of the ventricular wall, it's no longer there. And it causes a very enlarged septum. So if you think about it, sometimes when it starts to pump out blood, it will close on the aortic valve. Okay, so it causes compression and the blood won't be able to go out. So you'll have syncope. Okay, this is what causes symptoms here, are angina, for example, because you have less blood supply. Now, the histology appearance is this. It's the cardiomyocytes are in haphazard organization and it's enlarged. Okay, that's it. So if you see the key term haphazard organization and large cardiomyocytes, think of hypertrophic cardiomyopathy. Okay. Now, can someone tell me whether this is a form of dilated, restrictive, or hypertrophic, and what this is specifically? Excellent, good, mashallah. This is amyloidosis. This is restrictive. How do you know this is amyloidosis? I want description that this is amyloidosis. Good. Excellent. Apple green bifringes. You do Congo red staining and you look at it under polarized light. You see this. This is the green and there's blue also. So apple green bifringes. Okay. This. For the actual picture, the histology, all this material, not the center, but all around it, all of this, this is all amyloid. Okay. So this is all amyloid deposition. Amyloidosis, systemic disease, causes deposition of amyloid all over the place. A disease that you guys already have studied before that causes amyloidosis, but it's very local, is Alzheimer's disease. Okay, so that's one of the forms of amyloidosis. This is another one. This is more systemic in this case. If it causes restrictive cardiomyopathy, it's a systemic amyloidosis. Okay. Now, this one I won't quiz you guys, but I want you to remember these things for your exam. Cardiac MRI, you want to see the ventricular walls. Okay. You want to see if there's infarction. You want to see if there's myocarditis, and you want to see, what are the subtypes. So in this case, you have MI, you have myocarditis, and amyloidosis. For the finding specifically, honestly, I don't really know what's the difference between them. All three of these. I think this one is just more shiny appearance. So you think of amyloidosis, and you have the signs and symptoms. What I wanted you guys to remember is very importantly is which modality to use for what. So for example, if I have a patient with coronary artery disease, which modality do I use to assess the coronary arteries? CT, for example. Okay, CT angio. Okay, or you can use angiogram. Good, excellent, good. If I want to assess functionality, which image modality do I use? Echo, okay, to check for the ejection fraction. Good, excellent. If I want to assess the ventricular walls, which modality do I use? The wall itself. It's echo is for function. You want to use echo for function. MRI if you want to see the muscle itself. You want to see the tissue. Okay, so that's that. What is the initial image of choice for anything? Initial image. X-ray, excellent. So these are the very most important things that you remember from these modalities, okay? I didn't bring them all. I only brought one, and then just exactly for wall thickness, you want to see MRI to assess why. Why is there wall thickness? What is it caused by? Okay. So now I have some X-rays. I want you guys to know what they are. For this one, what is seen in this image? Cardiomegaly. Okay, excellent, good. Let's go very fast in this one. Now this one. What is seen in this image? Give me the disease. Congestive heart failure. Good. Left or right? Heart failure. Why left? Exactly. Left will cause pulmonary congestion. So this is because of congestive heart failure. So the reason why I know exactly this is congestive heart failure is this. This is the most important signs. These little lines over here on the side, okay, and obviously the case will be hinting towards congestive heart failure. Okay, so I'll mention that. Always the case will hint towards it. But the most important finding on chest X-ray for congestive heart failure is curly B lines. Okay, curly B lines. What is curly B lines? It's a sign of pulmonary edema. Okay, this is because of pulmonary edema. Left heart failure, you're not ejecting blood. It's going to backflow to the lungs, causes pulmonary edema. Later on causes pulmonary hypertension. Then later on causes cor pulmonale, right heart failure. Okay, so these are the more important signs. Curly B lines. You might see cardiomegaly because of the heart failure itself. Interstitial markings because of the pooling of the blood in the lungs, and causes thickening of the walls. For example, this is one of the interstitial markings that you can see. Okay. And then pleural effusion, you might see it. In this patient, I do not see pleural effusion, not gonna lie. There's very slight over here, but yeah. Okay, you got the point. Most important finding is curly B lines. Okay. Is this clear to you guys? Okay. So that's it for cardiology. And this is actually the majority of it. Okay. For pulmonary, I have slides, obviously, and I have a lot of conditions to go through. However, the majority of your OSPE will be cardiology heavy. Okay. Dr. Abrar loves to ask. However, for pulmonary, I will show you specifically which ones to focus on, and for radiology, what it's very important for radiology specifically. I have 0 micro in pulmonary because it's not going to be really asking your OSPE that much. I do not think, I hope not. However, just know, for example, keywords. For example, silver stain. If I think of silver stain, I think of Legionella. For example, I think of Pneumocystis jirovecii. I think of these organisms, okay? So stuff like this, okay? So now we'll start pulmonary. Do you guys need a break or should we continue so we can finish sooner? It's going to be similar style. Break. Do you guys want 5 minutes? Okay. That's 5 minutes and we'll come back. No. Okay. So now for the second section, it will be on pulmonary. I'll be going over the major topics as I mentioned. And I want, again, the same thing as we've been doing. I want you guys to be interactive, okay? So I'll be asking questions and so on and so forth. Okay. So now for pulmonary, the first thing I will do is I will just be briefing you guys on a normal chest CT, because it's going to be very important to be reading chest CTs and respiratory and pulmonary, okay? Very important. So now, for chest CT, this is a lung window, obviously. You can see that the lungs are very clear. You have the heart over here, and you're not going to be obviously seeing it as much. You have the trachea, and this is, I think, one of the main bronchus, okay? This is going to be the right main bronchus, okay? Here you can see that the lungs are very clear, okay? Very important, very clear lungs. You can see some interstitial markings, which are normal because of the blood vessels that are going and the interstitial, normal lung, okay? Now, we'll go over some of the abnormal ones as we go through these slides. Now, can someone identify what A is first? Good job. So this is emphysema. Now, emphysema, what type of lung disease is it? Is it chronic obstructive or is it interstitial restrictive? Obstructive. It's COPD. Okay, it's one of them. So now, in emphysema, you have destruction of the alveoli. Okay, so this causes a lot of space. Okay, there's a lot of space in the lungs, in the alveoli, which is going to cause more air to be trapped into the lungs. This is important to remember that there's more air now in the lungs. There's less ability to release that air. There's less ability to release that air into, there's limited expiration. So there's more volume now in the lungs. Okay, that's one thing about emphysema. What's the most common cause of emphysema? Smoking. Good. What type of emphysema does it cause? Centrilobular or panacinar? Central. Okay, centrilobular. What's this picture here? Okay. So smoking will cause a central lobular, which is the most common, as we agreed. The other one is something called alpha-1 antitrypsin deficiency. Okay, what causes the alveoli destruction is you have a lot of inflammation. Okay, a lot of inflammation that's destroying the alveolar walls. So what is causing these inflammation? What's the marker? It's going to be elastase, proteases, whatnot. Okay. What's something to defend it? It's antiproteases, such as alpha-1 antitrypsin. So if you have deficiency of alpha-1 antitrypsin, such as in the disease, alpha-1 antitrypsin deficiency, it will cause panlobular. So all of the lobule and the alveoli, the whole acini to be destroyed. Okay. So why is this in the liver? Is the alpha-1 antitrypsin is made in the liver. So you'll have a lot of alpha-1 antitrypsin that's in the hepatocyte itself. It's not being able to be released from the hepatocyte. This causes cirrhosis in these patients. Okay, so they will have also cirrhosis in these and with the emphysema. Okay, so that's emphysema. Obviously, know the changes in the what's it called, in the spirometry. Okay, know the ratios and know which one causes an increased ratio or which one causes decreased ratio. In emphysema, is it decreased ratio or increased ratio? The PV1, it's decreased. Okay, good. Excellent. Now for B, what is B? Good job. This is chronic bronchitis. So chronic bronchitis, how is it diagnosed? Clinically, or do you have to do lab investigations? Clinically. Good. More than 3 months, more than 2 years. Okay, remember that's for chronic bronchitis. What causes chronic bronchitis? What's the most important what's it called, risk factor? What's the most important risk factor? Smoking. Good. So now, what happens in chronic bronchitis? You have there's a lot of mucus glands. Okay, so you have hyperplasia of the mucus glands. So you have so many mucus glands. As you can see, this is one gland, this is another gland, this is another gland. Sorry, not hyperplasia, hypertrophy of the mucus glands. Okay, so the walls in the bronchi will be very thick. Okay, this is why it causes the same thing in COPD, and obviously COPD is a mixture of both diseases, a mixture of emphysema, chronic bronchitis. That's what causes COPD. Subtypes, emphysema, chronic bronchitis. Usually it's together. Chronic bronchitis, thickening of the smooth muscle walls, okay, because of the mucus hypertrophy. Okay, that's an important thing in chronic bronchitis. So now, can someone tell me what is in this image specifically? What is seen, what is the sign, and what is the disease? Okay, this is chronic bronchitis. This is not bronchiectasis. Okay, let's talk about what is chronic bronchitis. It's going to be in the bronchi, okay, or the bronchioles. So it's going to be in the little bigger, what's it called, airways. Okay, so that's number one. Number two is it causes increased thickness of the walls. So if you see increased thickness, you'll see something like this. This is called peribronchial cuffing. Okay, very important sign that we see in chronic bronchitis. Okay, and again, as I said, it's not really important to diagnose by X-ray. It's mostly clinical diagnosis. However, if you see this sign, think of chronic bronchitis. Obviously, clinically related, it's not really important, just for imaging and your exam purposes. This is called peribronchial cuffing. Okay. Now, if there's anything that they're going to examine you on in either SAQ, OSPE, or MCQ, it's this specific image. Okay. Can someone tell me what this disease is? Emphysema. Excellent. Good. What did I say was a pathogenesis? You have increased destruction, so it causes air trapping. Okay. So remember air trapping. So all the lungs is hyperinflated. Okay, if you want to say it like that. So now, what happens here? Important signs. Number one, can someone tell me what I am showing in this? What is this sign? Increased AP diameter, increased anterior posterior diameter. What is this? Exactly, increased retrosternal space. What happened to the diaphragm? Flat. Okay, that's another sign. What happens to the heart? Nothing actually happened to it's not actually a finding in the heart, but because of the hyperinflation, you have, it looks more thinner now, okay, because of the amount of air in the lungs, okay? So that's that, it just looks thinner. Another thing is the amount of ribs you can count. You can count way more ribs, okay, in these patients. You can count up to actually 12 in these patients, okay? This is emphysema, we agree, and these are some of the findings, okay? Flattened hemidiaphragm or LOSA, you can see the 11th to 12th rib, retrosternal space, increased AP diameter, long thin heart, widely spaced horizontal ribs, okay? I have no idea what this is, not gonna lie. You don't need to know this, I don't think. And increased radiolucency of the lungs because of the air trapping, okay? Is this clear to you guys? Very important high yield information about emphysema, okay? Emphysema also clinically, emphysema, pink puffers, chronic bronchitis, blue bloaters. You'll have cyanosis, clubbing, and chronic bronchitis, okay? Emphysema, they'll usually lose weight because of the amount of respiratory effort that they will need, and so on and so forth. And obviously, to manage it, you have the drugs that you can use. I think it's at the very end of your asthma lecture, if I remember. Okay, so that's how to treat COPD. Okay, most important causes for both of them is smoking. For emphysema, you have alpha-1 antitrypsin. And obviously, for classifications, I mentioned two of them, the central lobular epanacidine. There's more. Okay, there's like two more, I think, or one more. Remember those from your lecture. Now, what disease is associated with this image shown? What is this image? What does it show? And what is the underlying most likely disease? Bronchiectasis. What underlying disease does this patient most likely have? Cystic fibrosis. Good, excellent, good. So bronchiectasis is dilation of the bronchial walls. Dilation, very large bronchial walls. Why does this happen? Is because of recurrent inflammation. You have fibrosis. Fibrosis causes to pull the walls open, okay? So this is bronchiectasis. With bronchiectasis, you will have recurrent infections. Why? Is because of the dilated bronchial walls now, you'll have increased mucus that can sit in the bronchial walls. Because of the amount of mucus that can sit, it's a perfect house for these bacteria to come and infect it, okay? So because of this, you'll have recurrent infections. This will cause the bronchiectasis to become worse and worse and worse and worse. Signs of bronchiectasis are, for example, sputum, very productive cough with a very smelly sputum. You have, for example, clubbing that you might see, and you have signs of cystic fibrosis. You have, all the other things, okay? Another disease that you can see bronchiectasis in is something called Cardiac syndrome or primary ciliary dyskinesia. I think in your clinical lecture, he might have mentioned it. But just for you to remember, is because the cilia is not moving. So you'll have mucus that sits there, recurrent infections. Okay, that's it. For bronchiectasis. Now, we finish now from the COPD. Let's go into the interstitial lung diseases. So first thing is, in interstitial lung disease, it's inflammation of the interstitium, which is basically between the alveoli and so on and so forth. Now, the most important finding that you'll see on biopsy or on gross image is honeycombing of the lungs. You'll see cystic areas and you'll see fibrosis between them, okay, reticular areas. So this is the honeycomb appearance you can see on gross image. For CT, same thing, reticulonodular pattern. And also, just so you guys know this, is chronic interstitial lung disease. When we say the finding on X-ray, we usually call it usual interstitial pneumonia. No reason, I do not know why, but we just call it that. So you'll see here markings in the interstitium, very thickened interstitium, and you can see nodular patterns, okay? Even in this patient, you can see some bronchiectasis here and some cystic patterns over here. So this is what we call a reticulonodular pattern. This is seen in many interstitial lung diseases, okay? And we're gonna go a couple of them. And they're pretty simple to remember, all of them, and the key facts about all of them. On imaging, you cannot differentiate them. What you need to differentiate is how they present clinically and what is a risk factor. Okay, so radiology, they're all gonna be looking like this. Okay, and I'll go over them one by one. So now, this one, can someone tell me what disease is shown here? So excellent, good. This disease is idiopathic pulmonary fibrosis. Okay. From the name, is there a cause for it? Do we know a cause? No, it's idiopathic. So in idiopathic pulmonary fibrosis, the most important thing that he will want you guys to remember is the fibrosis. Okay. So you can see fibrosis right here. This is normal lung tissue. You can see that the walls are normal. It's thin. Here you have fibrosis in the walls. Okay. So that's this. If you look at the gross image of a patient with interstitial pulmonary fibrosis, it will be a cobblestone appearance. Okay, very important key term to remember, cobblestone appearance. Now, for the chest X-ray, you'll have pulmonary infiltrates, for example. Here you can see some like interstitial markings, okay, as we call it. So basically thickening in the interstitial. It's not very specific, okay? But if you look at this, you might think it is pulmonary fibrosis. What exactly? You'll have to rule out some specific causes, then you reach pulmonary fibrosis, okay? So now, what's some causes of pulmonary fibrosis that we know? Give me like the big term. Usual interstitial pneumonia is what we call the radiology finding. The thing I was looking for specifically is pneumoconiosis, okay? Which is basically because of inhalation of something, you'll have fibrosis, okay? So now, let's go through those one by one. And it's important, these are important to remember what they look like. From the other slides, bronchiectasis, I'd say, is a major thing that they might test you on imaging, okay? Or like what it looks like. Now, these. Can someone tell me which form of pneumoconiosis is seen? Co-workers. Why is it co-workers? Very simple. Why is it co-workers? Good. Black. Carbon pigmentation or blackening of the lungs. Here, this whole thing is fibrosis. Okay, number one. Okay, it's just thickening. The black pigment tells you it's cold. Done. Now, for co-workers pneumoconiosis, can it cause TB? Yes or no? No. What's the complication of co-workers pneumoconiosis? Progressive. Good. What I need you guys to remember, co-workers leads to progressive massive fibrosis. It causes pulmonary failure, okay? Because it's very thickened. It's massive fibrosis. Look at the size of this one over here, okay? So you're not going to be able to breathe properly. It causes restrictive lung disease and so on and so forth. The complication is not associated with the cancers or with the TB. Okay, there are specific ones that actually cause it. Let's go on to the next one. This is the major complication that I want you guys to remember. This, can someone tell me what disease is this? Silicosis, excellent, good. Who can get silicosis? What's one important occupation? Sandblasters. Excellent. Okay, that's a major important one that I want you guys to remember, sandblasting. Okay, so now they inhale the silica particles and it's going to appear as this image as a silica nodule. It's a one big, huge nodule. Okay, now what's on the other image? Can someone tell me what this other image is? Bifringens again. What was the other bifringen thing that we mentioned? Amyloidosis. Good. So you'll have these silica nodules, okay? These shiny little silica nodules. These are the bifringent patterns that you can see in silicosis. Now, give me the complication for silicosis. Is it complicated by cancer, by TB, or by progressive fibrosis? TB. Now, it is complicated by TB. Excellent. Good. The reason why, and I do not think he explained this to you, and why it actually causes TB, is because what's the most important cell in TB? In the to contain TB, what's the most important cell? Macrophages. One of the functions of macrophages is phagocytosis, and then you'll have the formation of the phagolysosome. Silica will impair that function. It will impair macrophage function. That's why they have increased risk for TB. Silica specifically. Okay, and I do not think they explained this to you, so this is me telling you why. Okay, so at least it makes sense to you guys. Clear? Okay. So now, what is seen in this image, as you can see? Can someone tell me what this image? Excellent, good. So this is ground glass opacities. Ground glass opacities happens because of pulmonary, there's high amount of fluids in the alveoli, or there's pulmonary edema or something. Okay. So this is in early stages of some of the interstitial lung diseases. Okay, it's a ground glass appearance. What that means is if you put, like, for example, a glass panel or whatever, you can see through it. Okay, so this is what this is basically. Okay, this is why they call it ground glass. However, I honestly, personally speaking, I do not know why they call it ground glass opacity, but this is what ground glass opacity is. It's the early stages of all of these interstitial lung diseases. Later on, it will cause these reticulonodular patterns. Okay, later on, because it causes the reticulations, because of the interstitium that's being fibrosed, that's being thickened, for example, and it can cause, because of the fibrosis itself, as I said, in bronchiectasis, it causes the fibrosis, what will cause the thickening, or sorry, the widening of the bronchi. Okay, in this case, since it's a small airways that's being affected, the alveoli, for example, and the acini, it's going to cause these nodules to form because of the fibrosis. Okay, so this is, for example, interstitial lung disease, usual interstitial pneumonia, as I mentioned. Okay, these are the reticulonodular patterns that's seen in many of the interstitial lung diseases. This image, once you see a case on interstitial lung disease, you see this image, answer interstitial lung disease. Okay, in your radiology, at your second lecture, there's 4 images that has different forms of it. Honestly, we got questioned on one of them. I honestly do not know any of these diseases that she mentioned. There's 4 images on top of each other. Just skim through those 4 images specifically. Remember, like, a sign or two from them, and then that's it. But the most important thing from that whole lecture was emphysema and this. Okay, the interstitial lung disease markers, or the findings, reticulonodular pattern. Okay, so now, is that clear to you guys, to what to remember, what to know for the exam? Good. Okay, so the next thing will be this. Can someone tell me what this disease is? Asbestosis. Excellent, good. So this is asbestosis. So you can see in the pleura, you have pleural thickening. Okay, pleural thickening because it affects the pleura. Okay, so which workers are exposed to asbestos? Shipyard. Give me one other. Okay, specific answer I'm going to look for is plumbers. Okay, plumbers and shipyard workers. Okay, two important occupations that will come in the scenario. Okay, so once you see shipyard, once you see sandblasters, any of these, think of these diseases. Okay, so now shipyard workers, plumbers, inhale asbestos. Years later down the line, it will come with pleural thickening, pleural effusion, whatever. Okay, so this is one of them. Now, if you take a sample, you'll see this asbestos body, or there's another name for it, I think fumo whatever body. Anyways, these are asbestos bodies. Once you see these things, okay, this is asbestosis. Now, give me a complication from asbestosis. Furogenous bodies. Excellent. Good. Cancer. What specific type? Mesothelioma. Excellent. Malignant mesothelioma. Okay. So can someone tell me what is seen in this image? Perfect. Okay. Pleural thickening or pleural plaques and pleural effusion. Okay. This whole left side, there's effusion. And then you have thickening all over. Asbestosis and malignant mesothelioma commonly can cause pleural effusions as one of the things that it can cause. Okay. So that's that. Now, can someone tell me what disease is shown here? Sarcoidosis. Good. Let's go image by image. Okay. This first image, what is shown in this image? Non-caseating granulome. Okay. You won't see caseous necrosis in the middle. Okay. You'll see a granulome. Okay. That's number one. Okay. It's a non-caseating granuloma. Caseating granuloma is what disease? TB. Important to remember. Good. What is this body over here? Shaman. What is this specific thing in shaman bodies? Why do we say this is shaman? Calcium. This is calcium deposition. This is why we say this is shaman bodies, because it has calcium in it. Okay. So this is shaman. What is this one? And by the way, you are right. These are giant cells, but it has characteristic intercellular findings. This one, shaman bodies, was calcium. This one is the asteroid bodies, and it has these figures inside. I don't know how to describe it, but it looks like not even asteroid, it's a star. Okay, that's inside this. Okay, remember these two, and it's in sarcoidosis. In terms of clinically, I do not think it's as important to remember how it presents sarcoidosis, except one thing, and which is this. What do you see in this image? Perfect. Bilateral hilar lymphadenopathy. This is very important. Okay, so sarcoidosis itself is a multi-system disorder. It can affect multiple systems. It can most commonly happens in females, for example, and it presents with bilateral hilar lymphadenopathy, dyspnea, signs of restrictive diseases, and it causes, most importantly on imaging, bilateral hilar lymphadenopathy, very characteristic of sarcoidosis. And then you have, obviously, it's a non-caseating granuloma once you take biopsy. Okay, so now what disease is seen in this image? Pulmonary embolism. Excellent, good. Okay, so this is a pulmonary embolism. So let's go from the CT and then go left. Okay, so from the CT, you can see, excellent, someone mentioned a saddle embolus. The most important finding you can see on a pulmonary embolus, okay, is going to be a filling defect. Okay, because obviously if it's going to obstruct the flow, everything after the contrast, because this whole thing is contrast, as if you guys remember from my radiology crash course last time, that the white appearance is because of contrast. You can see the aorta is white. So contrast, once you give it, everything after the occlusion will be darkened. The contrast won't go. So this is what we call filling defect. What type of imaging technique is this? Middle one. VQ scan. Excellent, good. So this one is assessing the ventilation. This one is assessing perfusion. And as I said, this is going to be filling defects. Okay, it's well ventilated, but not perfused. Okay, good. On gross appearance, you have this. This is called a wedge infarct. Okay, everything distal is going to be compromised. You'll have ischemia. Okay, so that's it for pulmonary embolism. For signs and symptoms, you have signs of DVT, you will have high D dimer and all these things. Okay, important to remember for pulmonary embolism. You have a female who has not moved, for example, for a very long time, you know, for example, traveled recently, or someone with already a coagulation disorder presents with, you know, signs of tachycardia, dyspnea, respiratory distress. You'll see this. You do lab testing, you'll see elevated D dimer, you think of pulmonary embolism. Okay. So that's it for pulmonary embolism. Yes, oral contraceptive is a risk factor, yes. Now, for the next thing is pulmonary hypertension. Pulmonary hypertension is, from the name itself, it's high blood pressure in the pulmonary circulation, okay? Can someone tell me the two findings that you can see here? Plexiform, which is this one, and medial hyperplasia, okay? So, or hypertrophy. So you'd have firstly medial hypertrophy, okay, because of the blood pressure. It's very elevated. It could be idiopathic. It could be due to congestive heart failure. Could be due to COPD. There's many causes of pulmonary hypertension. Anyways, because it needs to adapt to these changes, it will increase in size. So you'll have smooth muscle proliferation and endothelial proliferation, which is what's causing this plexiform lesion. Okay, the capillary that's, you know, there's a lot of proliferation that's happening. Now, this plexiform lesion in pulmonary hypertension is a late appearance, okay? It's a very, very late appearance. You might not see it. However, it's characteristic of pulmonary hypertension. Remember these two images. Now, I'm going to go through pneumonia very fast, okay? So pneumonia, there's many stages of it. It's an infection, obviously. There's typical pneumonia, atypical pneumonia, whatever, okay? So the most important thing to remember about pneumonia in your OSPE is the stages of pneumonia. This, I can guarantee you will come, okay? And remember that. And I'll specifically tell you which one to remember. So the first one is congestion. From the name, you'll have congestion based on cells, okay? You'll have a lot of cells going in, and specifically you have neutrophils that's starting to proliferate in there. You'll see, for example, a lot of red cells. The next stage is going to be red hepatization, which is going to be more marked congestion, okay? It's way more. It's colored red because there's so much red blood cells, so many red blood cells now. This is 3 to 4 days, okay? So the first one, congestion, the first 2 days. Then 3 to 4 days is red hepatization. The reason why we call it hepatization is going to have the consistency of the liver, okay? Then these red blood cells will start to lyse, okay? And you'll have disappearance of these red blood cells. So this is what we call it to become gray hepatization. And in gray hepatization, we'll have something called consolidation. I'll explain what consolidation is in the imaging sections. So this is gray hepatization, day 5 to 7. Day 8 to, however, 1 month, okay, you'll have resolution, which is by fibrosis, okay? That's that. Based on this, can someone tell me what this is? Congestion, excellent. Good. Okay. Early red hepatization / congestion. It's very hard to tell the difference, okay, between them. This is most likely not going to come for this to tell the difference between them in terms of imaging. It's very difficult. However, here you can see congestive capillary and neutrophil exudation. Because of the neutrophil exudation, that's why we say it's early red hepatization. Okay. So all of you are correct. This is very difficult to tell. What's not difficult, and it's very important to tell, is this. Very important. This one specifically. This one is gray hepatization. Upper lobe or lower lobe? of the lung? Lower. Excellent. Good. Okay. Excellent. If anything, this is what's going to come. Okay. This specifically is going to. Okay. So remember this specifically. For the image, same thing. Histology is a bit more difficult to tell, but basically you'll have less congestion than before, less amount of red blood cells. You can see red cells right here, red cells, whatever. You get the point. Here, there's far less. Okay. You won't be able to see red cells. Okay. That's it for this one. The next one is obvious also. Very obvious to tell. Which stage is this? Resolution with fibrosis. This thing, these swirls over here, is fibrosis. Okay, clear? This is organization or resolution. Okay, with fibrosis. Excellent, good. Okay, that's it for pneumonia. Okay, if anything, remember this image. Very important, this image. And this image can come because it's easily, you can tell fibrosis. Okay, remember the timings as well and what cells are important in which. For example, the first one is mostly red cells, then you have neutrophils, then you'll have this integration of these neutrophils, red cells, which is great hepatization. Then you have fibrosis. Okay, so now, can someone tell me what disease is seen in this image? TB, excellent, good. So what can you see on the chest x-ray? Cavitation. Is this an primary TB or latent? Latent reactivated? Secondary, good. Perfect, excellent, good. So what can you see on histology? We already mentioned it. So since we already mentioned it, let's move on. Caseous necrosis, okay? Caseating granuloma with caseous necrosis in the middle. Okay, so obviously granuloma, giant cells. That's one way you can remember them and see them. Okay, you have these giant cells. Okay, TB. Now, that's high yield. TB is very high yield. This will most likely come. Okay, now let's talk about this and try to make it make sense. So firstly, what is this telling you? Is there's changes that's happening to the mucosa, okay, to the walls. Why is this happening? So if you have chronic insult, okay, something that's chronically damaging the walls of the trachea, of the airways, it's going to try to adapt to these changes, okay? It will reach a point where it can't adapt to these changes anymore, and it will try to change these types of cells that can properly handle this insult. Two areas that this can most commonly happen: esophagus and in the lungs, in the airways. Okay, in the lungs because in the GI and the esophagus because of the acidity, it causes changes. Here in the lungs is because of smoking, most commonly. So let's go over it one by one. The first thing, A. What changes can you see in A? Let's say someone's smoking. The first change that's going to happen, what do you want to get rid of the smoke? Or get rid of this insult? Increase mucus production through what cells? Goblet cells. Okay, so goblet cell hyperplasia. These big giant cells are goblet cells. Good, we agree on that. Goblet cell hyperplasia. First changes that happen. Second stage, you already had goblet cell hyperplasia. It's not working. You want to do what? Because what is the wall itself? What is this epithelium? So we can establish that. What is this epithelium? Columnar. So what's changing here? What's happening here? Not yet dysplasia. Basal cell hyperplasia. So in the walls, or in the layer, sorry, of the epithelium, always the basal layer is what's going to differentiate the rest of the layers. Okay. Once you have genetic changes that's happening in the basal cells, everything else will follow with it. Okay. That's just concepts. So now, you're changing the basal cells are proliferating, okay? Because now you want multiple layers to fight the offending agent, okay, which is smoking. So the next thing is squamous metaplasia. It's now changing into squamous cells. So now it's gonna try to offend this the smoking. Okay, so you have squamous metaplasia. Okay, the squamous cells are better at protecting, the airways rather than columnar cells. So what's this image here? After you have squamous metaplasia, what's happening? This is dysplasia. Okay, so now it's gonna be transferring into a tumor. Okay, or into cancers, dysplastic process. Why? Because smoking itself is a carcinogen. Okay, so this is dysplasia. How do you know that this is dysplasia? Disordered. Okay. Polymorphic. Okay. Important thing to see. Look at the nuclei colors. It's all basophilic, all blue. Here, for example, you have something called the what's it called? The apex to basal orientation, where basically the basal cells are going to be the darker cells. Then it goes into becoming the lighter cells. Okay, I forgot what it was called, the actual term. But anyways, this is how you know this is dysplasia. What is this? Squamous carcinoma in situ. Okay, in situ means what? Why do we say in situ? Hasn't infiltrated the basement membrane. Good, excellent. So this is within the basement membrane. Here you'll have all the signs of malignancy. Okay, here you'll have increased NC ratio, poorly differentiated, whatnot. However, it's in situ since it doesn't cross the basement membrane. Okay, this carcinoma in situ. Here, end stage, it crosses the blood-brain, not the blood-brain, the basement membrane. So it's called what? Squamous carcinoma. Okay, it's no longer in situ. Clear, guys? This high yield. This will come. Okay, let's move on. What is this disease? Squamous cell carcinoma. The first image. What is seen in this first image? Keratin pearls. The second image. Desmosomes. This thing right here, you can see the lines that's going from one cell to another. These are the desmosomes. Okay, or you can call it intracellular bridges. Okay, desmosomes, intracellular bridges, same thing. Okay, so this is squamous cell carcinoma, keratin pearls, desmosomes. Good. Let's move on. What type of cancer is this? This one is adenocarcinoma. So the precursor lesion for the what's it called? Adenocarcinoma is the atypical adenomatous hyperplasia. Because it firstly causes hyperplasia, then it will cause the cancer. Now, the same thing, it will have an in situ, then it will have a full-blown carcinoma. This one is called bronchoalveolar carcinoma. Okay, this one is in situ. Okay, because it's within the basement membrane. Excellent. Someone already mentioned in chat. Now you have two different types of cells that actually causes this. You'll have the mucinous or the non-mucinous variant. Mucus, okay, mucin, it's white. Okay, so once you see white cells, this is mucinous variant. Darker cells, I don't actually have an example, but let's just say like this part over here. It's much darker, so it's non-mucinous. Okay, now adenocarcinoma itself, it's a glandular tumor. It's glands. Okay, so you'll see glands. Okay, that's why we call it adenocarcinoma. So that's number one. Number two is majority of adenocarcinomas will be mucinous. Okay, so when you do a mucin stain, for example, here it will be positive. Okay, here you can see glands, mucin. Okay, here this is called thyroid transcription factor. It's also positive in adenocarcinoma. Okay, that's just a low yield information, but remember it, if it's a key term that comes, remember it's CTF positive. Okay, so this is adenocarcinoma. Differentiating squamous cell and adenocarcinoma. And also the next tumor that we're going to talk about is location. Location risk factors, for example. Okay. Adenocarcinoma, is it related to smoking? Good. No. Squamous cell carcinoma and the small cell carcinoma, is it related to smoking? Yes. Okay. Excellent. Good. Which one is centrally located? The ones which starts with S. Okay, excellent. Good. Adenocarcinoma, peripheral. Okay. Good. So now identify the diseases. Small cell, large. Excellent. Good. Small cell, from the name, it will be very small cell, large cell, big cells. Okay. Now, important to remember between the two is large cell is exclusion. If you can't diagnose any, like if you can't reach any other tumor, you diagnose with large cell. You take biopsy, you see large cells, large cell. Small cell. Small cell, what's the origin of small cell carcinoma? It's neuroendocrine. Important. It's neuroendocrine. So tell me, what markers will be positive? Chromogranin, synaptophysin. Good. Chromogranin, very important. High yield information, chromogranin. Okay. There's also another one in the slides, so I forgot which one it was. So anyways, there's those markers, very specific to neuroendocrine tumors. Small cell carcinoma is one of them. To differentiate also, to remember about small cell carcinoma, is it a perineoplastic disease? What does it cause? If it's a perineoplastic disease, what? Okay. Okay, so it causes SIADH and it secretes ACTH. So if it's ACTH, it will cause Cushing's. This is small cell. Squamous, PTHRP. Okay, PTHRP, the parathyroid hormone-related peptide, which will cause hypercalcemia. Okay, so that is for squamous. This is for small cell carcinoma. Cool. Let's move on. It's not Addison's, it's Cushing syndrome. Okay, Addison's is completely different. It's the opposite of Cushing. Okay, let's move on to this one. What diseases is seen in the image shown? Just one specific disease. Good. This is hamartoma. Okay, so hamartoma is a benign tumor. What's the definition of hamartoma? Hamartoma is a normal tissue in an abnormal location. Okay, it's a normal collection of tissue, normal tissue, not dysplastic, not cancerous, in just abnormal location. Okay, so in this one, you see high amount of collagen here. You'll see some epithelial cells as well, but the key thing is, are you supposed to see collagen in the lungs? No. Okay, so you'll see collagen. Here, importantly, and someone already mentioned it, is you have popcorn calcification. Okay, now I want to just briefly mention about X-ray findings. You need to differentiate what is benign lesion and malignant lesion based on the characteristics. If this is a round lesion, small, it's like around 3 centimeters or so, or less than 3 centimeters, think of it as a benign lesion. Okay, if the walls are rounded, if it's not, for example, spindles, there's not things coming out of it, this is benign. If the opposite, if it's a big mass, more than 3 centimeters, if it's causing like infiltration to the rest of the tissue, like it's not a regular border, think of this as a malignant feature. Okay, this explains some, like most of the radiology lecture from the third lecture. That's all you really needed to know. Once you see something that has like these infiltrates, it's large, more than 3 centimeters, think of a malignant feature or malignant tumor. Okay, so that's the difference. This one of the most benign ones, popcorn calcification, key term. Now, what disease is shown here? And we're almost done, guys. This is mesothelioma. Good. Okay. So this is malignant mesothelioma. Malignant mesothelioma is a complication of asbestosis caused by asbestosis. Okay, most commonly. There's two variants, not as important to remember these two variants, but you have the epithelial variant, and then this is I forgot actually what it was called. The sacromatous. You'll see spindle cells and high NC ratio cells, very dysplastic cells. Okay, this is the sacromatous variant of malignant mesothelioma. It's not as important to remember the two variants. I don't remember it coming at all for us. So yeah, and I don't remember it being too high yield. But the most important thing is remember the cross finding, which is very it's now spreading. Okay, it's not only limited to the pleura. Okay. Now, remember last time I mentioned carcinoid syndrome or the carcinoid heart disease? This is the actual carcinoid tumor. It can happen mostly in the GI, most common location, spreads to the liver, then causes the carcinoid syndrome. It can also happen in the lungs. Okay. Now in the lungs, you can see this. This is a neuroendocrine tumor, same thing. Okay. And I don't think he mentioned this to you, so I will just briefly mention neuroendocrine tumors. Once you see the nuclei, there is a specific salt and pepper look to it. So you can see these white spots, these are the salt, and then there's pepper, which is the dark spots. Okay. This is for neuroendocrine. It all looks the same. The cells all look the same, so it's a monoclonal appearance. We also say it's a boring appearance because they all look the same. Okay. And the most important thing about it is it secretes serotonin. That's it. Okay, that's it for carcinoid syndrome, tumor. Now, we're at the very end. We're going to go over some important radiology concepts, and we're done. Okay? So the most important things in radiology X-ray is consolidation, interstitial markings, atelectasis, nodule, and mass. Nodule and mass, I've already covered. So nodule is less than 3 centimeters, mass is larger. Okay, consolidation. Consolidation is you have fluid in the alveoli. Okay, most common condition causing consolidation is pneumonia. Pneumonia will come with consolidation. You'll have diffuse consolidation, you'll have patchy consolidation, you'll have local consolidation. Depending if, for example, if you have lobar pneumonia, would you expect diffuse or local consolidation to where the lobe is? Local. Okay, makes sense. So that's what consolidation is. Okay, and it's very specific. You have diffuse if it's all over the lungs, if it's atypical pneumonia, for example, or you'll have local consolidation. Interstitial markings, we've already seen. If you have someone who has, for example, congestive heart failure, you'll have some interstitial markings as long as you see curly B lines, this is congestive heart failure. Now, interstitial markings can also be seen in interstitial lung diseases, as we mentioned, okay? The usual interstitial pneumonia, okay? Nodule is a nodule, mass is a mass. Atelectasis is a collapsed lung, okay? It's not pneumothorax, it's collapsed. It can be pneumothorax, it can be hemothorax, it can be anything. It's a collapsed lung, okay? This one also is specific to a location, okay? So now, these images, honestly, these are like, this lecture killed majority of us when we studied it. Some of us actually skipped this, but I'll just tell you to remember the key concept and how to tell it. If you have signs of pneumonia, think of consolidation, then you think, okay, if this is how it looks like, this is diffuse consolidation. This one is, I cannot actually see this because I have the chat covering it. Low. Anyways, you can see lobar consolidation over here. Okay, so it's specific to the lobe. This is, for example, if you have a patient with lobar pneumonia. Multifocal, there's multiple areas. It's not diffuse all throughout the lungs, but it's multiple areas. So for example, you have consolidation over here, you have consolidation over here. And again, consolidation just means there's fluid in the alveoli because of inflammation, for example. Now, atelectasis, as you can see, is collapsed lung. And you will see this line. There's a distinct line that will differentiate between the normal lung and the collapsed lung. There's a line. Okay, so you can clearly demarcate the differences. This is why this is atelectasis and this is consolidation. Consolidation, you cannot tell the difference between normal and abnormal based on just a line. Okay, there's no line of demarcation. Okay, fine reticular interstitial. Okay, we mentioned the interstitial marking, it's all over. Coarse, okay, it's not as important to differentiate them, but just remember the interstitial markings, which are these lines. Okay, there's lines going all over. Okay. Now, for the masses, you'll have a small nodule, less than 3 centimeter, and then you have mass, okay, or masses. And I'll go into this one specifically later, okay? So this is this. So now this is a more detailed look at it. This is consolidation pneumonia, I think, okay? This is lobar pneumonia since it's one area, okay? So this is focal consolidation. Okay, if it's more diffuse, do you think diffuse? If it's multifocal, it's multiple areas. However, it's not diffuse, it's not all over the lungs. Okay. Atelectasis, you'll have a clear line of demarcation that's differentiating between the collapsed lung and the normal lung. Okay. Now, TB versus abscess. Abscess. What is an abscess? It's filled with pus. Excellent, good. That's important. If it's a cavity that's filled with pus, if you think about gravity itself, where is the pus going to accumulate? In the bottom of the, yeah, exactly, down, okay, in the bottom of the cavity. It's filled with pus. So if you think this is the whole cavity or the abscess, so this is an air fluid level. Because there's fluid that's accumulating in the bottom of the abscess, there's going to be a demarcating point between the air and the fluid, okay? This is why this is an abscess. This is a cavity. A cavity is not filled with pus. It's not filled with fluid. So you'll see it as just air, okay? Air pockets. Clear to tell the difference between TB and abscess? This is TB, this is abscess, okay? Now, can someone tell me what is seen in this image? This is many masses, okay? Okay, multiple masses. So you have one mass over here, a mass over here, a mass over here, another one here, and so on. Here you can see on CT multiple masses. To differentiate multiple masses from diffuse consolidation, you cannot pinpoint that there's a circle, a mass, or anything. It's just white, okay? This is why this is diffuse consolidation. Here you can clearly tell that there are specific masses. Why do we see this? When do we see this? Metastasis. Okay, something is spreading to the lungs. Once you see multiple masses, metastasis from somewhere else. Okay, it does not matter where else. Just know it's metastasis. What is this? I will accept 2 answers for this. Because I just want to mention a very important thing about this. Okay, guys. Good. You are recognizing that there is atelectasis, but I want you guys to mention what this circle is. Why is it there? Cavitation. Now, I want you guys to now think of something else. Which tumor can happen in the apex of the lung? Pancreas tumor. Can squamous cell carcinoma happen in the apex? Yes or no? Usually central, but the answer is not no. It can happen in the apex. Okay. So I want you guys to just be aware that it can happen in the apex. Apical stuff, think of TB cavitation. So if you have someone with signs of TB, fever, and light sweats, and so on and so forth, has TB before, so on, think of this. If you have someone who's a chronic smoker, think of squamous cell carcinoma. Think of pancreas tumor if he has, for example, ipsilateral Horner syndrome, you know, the arm pain, whatever. Okay. The reason for this slide is it's kind of messed up, not gonna lie, but think broadly. If you just see a cavitation, think of the most common, think of TB, sure, but be open that there's multiple causes. Okay. Look at the signs and symptoms. Now, I want to actually mention, thank you. I want to say something. What can tell me that this is cancer from this image? There's one specific sign, very specific. It's important in radiology. Excellent. Good. Trachea. The trachea is shifted towards the tumor. Masses think that everything's going to shift towards it. Why? Because there's fibrosis. Fibrosis will shift stuff towards it. Okay? Exactly. Okay? That's why this is cancer and not TB. Clear, guys? TB won't do this. Okay. And someone tell me what this is. To answer your question in chat, silica. Okay, this one is pneumothorax. What type? It's important to remember this is one specific type. Tension pneumothorax. Look over here. This whole lung collapse, gone. Okay? It's air. This is the remaining part. Another thing, very important, is the trachea. Okay? That's it. Once you see tracheal deviation, clear pneumothorax on this side, it's tension pneumothorax, it's an emergency. You need to treat it. Like it's emergent. This is tension pneumothorax. And that's it. And that's all for the OSPE review. Any questions? Or anything at all? Yes, I'll send the PowerPoint, of course. For pharma's part, I'd say honestly do as many questions as you can. The more questions you do, the more you remember. Know the mechanism of actions very well and know the side effects. The most important thing are mechanism and side effects. That's honestly yes. And also there are sources for questions for pharma. I think in CVP, the best source I had was pre-test pharmacology. This is one of the best I've seen for practice questions. Okay, for pharma. Ask AA heads if you want the resource specifically. If not, I can send it to you guys. Okay. All right, guys. Best of luck. And if you have any questions or anything, my number is in the beginning. So yeah, yalla guys, best of luck.